a challenge for me to remember to do that. All right, so what we'll do, we'll just walk through a couple of strips, and then we'll talk about we'll pull up the syllabus and talk about the few objectives that are for, actually, I think there's only 1 or 2 objectives for Peds cardiac, and it just says, good morning, Mapuola. It just says to know the cardiac anomalies, basically, is what the objective is. So we'll talk a little bit about some of the things that classify acyanotic and cyanotic, and some of the details of some of the other heart anomalies. So let's get started with this. So if you remember here, when you're looking at the basic ECG, let me grab my pencil here and change the color so I can draw a little bit. So right here, your P wave. Whoops, maybe it won't let me. There we go. That is your atrial depolarization. And when you come here to your QRS, this big complex here is your ventricular depolarization. It's bigger because it's a bigger heart muscle. Your ST segment coming right up here tells you sometimes if you have ischemia, whether it's starting now. So that's if it shoots up kind of high here and then kind of comes down like this to your T wave, or if it hangs out kind of low, where you've got where it kind of goes like this and then comes back up, then that's old ischemia down here. If it shoots up tall and then kind of comes down, that indicates new ischemia. It's a STEMI, ST elevation MI. That's happening right now. And that's something that you need to let your physician know immediately. This is your isoelectric line, this red line here. Anything that goes above is a positive deflection, and anything that goes below is a negative deflection. And that's where you kind of look to see if your ST segment is kind of hanging out too low or coming up too high, is if in relation to that line. Okay, so when you interpret, just make sure you walk through these steps, kind of just right in order. And then at the very end, look at this slide doesn't have it, but look at your premature beats or your pauses or your things that don't mix and match. So you look at your rate, too fast, too slow, or just right, your rhythm, the regular or irregular, and your P wave, if you have 1 for every QRS and if they look alike. Your PR interval. Don't worry about the time for now, but look and see if it's constant, like if it's changed or unchanged. If your P waves look different, then your PR interval is probably going to be different. It's probably going to be shorter or longer. And if you have a lot of P waves, like an atrial fib or atrial flutter, then that won't be applicable. Your QRS complex, if it's narrow or wide. Your ST segment, if it's elevated or depressed, and your T wave if it's inverted or peaked. So this one is kind of a cheater. It's normal sinus rhythm, so we'll move on. So here you would look and see, what is my rate? It's 40. What is my rhythm? If you put your fingers on the R waves and kind of march them across, you'll see that it's very regular. And then you look and see that you have 1 P wave for every QRS. They all look the same. So that means they're sinus P waves. They're coming from the SA node. And then that ST segment, so right down here, is coming right back to that isoelectric line pretty quickly. So no depression or elevation there. And then our T wave looks nice and round. So there's nothing that's wrong with this except that it's too slow. So you'd call it sinus bradycardia. So that one you probably knew was probably pretty easy for you. Let's see what we can. Okay, so I'll tell you what your rate is on here is 140. My little menu here on the side is kind of, I don't know how to drag it. So, so it is what it is. It's kind of over the end, but that is too fast. So then we're going to look at our rhythm. And if you put your fingers on those R waves and kind of march them across, you can see that it's very regular. Then you look at your P waves. You have one for every QRS. So you're looking here and here, here, all the way across. They all look the same, pretty unchanged. And so we know that those are sinus P waves coming from the same place. Then you want to look at your QRS. Is it narrow or wide? And it is nice and narrow. So with a P wave and a narrow QRS, you know it's coming from above the ventricles. This ST segment, it looks almost like it might be hanging out a little bit, but if you look at your isoelectric line, whoops, it's not drawing. It's coming right across here. Oops, sorry. It's not drawing very straight. You can see that it really isn't sagging, even though it looks a little rounded. And so you wouldn't necessarily call that ST depression. And then your T wave, sometimes people say, oh, that looks a little bit peaked there as opposed to rounded. And so if you question that, you would just look at your labs and look at your electrolytes. So the only thing that's wrong with this is it's too fast. So I would call it sinus tachycardia. This one's kind of obvious, but we'll walk through it anyway. So your rate is 50. Your rhythm, if you're looking at your rhythm that you want to find on some of these that might be a little bit different, you can take and look at that. Oh my heck, that went way up there. A little package of the P, QRS, and T that are all together. If you look at each one of those here and here and the one that's circled and here, they're all looking the same. So then I would count from your R wave to your R wave and to your R wave. It's very regular. And you should probably have one right here. And then you'd kind of go back. This misses, it's a little bit long. But then it kind of goes right back to that same regular rhythm. So I would call it a regular rhythm. But it's missing something right here. So we'll come back to missing beats or early beats at the end. So now look at your P waves. And you've got one before every QRS. They're all looking the same, nice and round. Whoops, that one didn't draw. And their PR intervals look unchanged. So those are nice sinus P waves. So I would call this initially a sinus bradycardia. It has a narrow QRS. And your ST segment looks just fine. And your T wave is nice and round, going the same direction as your R. So we know that those aren't ventricular beats. Those are atrial. So now we know that we've got this sinus bradycardia, but we have something else going on here. We're missing a beat, and so it's a big pause. So sometimes it'll be called a sinus pause. Sometimes it'll be called a missing beat. Sometimes it'll be called a sinus arrest. But for the most part, most of the time, it's just called a sinus pause. So you would call this a sinus bradycardia with a pause. All right, let's try just a couple more and we'll move to Peds cardiac. Okay, so now what's your rate? So I would say 30, 40, 50, 60, because I'm not sure if there's one behind that little menu. So we'll say 60. So we're in our 60 to 100. So that makes it right in the rate that we like. So not too fast, not too slow. And then you look at your rhythm. It's almost looking like it might be a little irregular. And so then I would try to find my my PQRST kind of package of beats that I like. It's hard to draw on this little mouse pad. All right, so I have a P wave there. I have a P wave there. I have a P wave there. So I do have one before every QRS, but they don't look the same. See there? That makes their PR intervals a little bit changed also. So if I'm wondering, well, they're all different. Do I have a narrow or wide QRS? It looks almost a little wide, but if you count your boxes, it is below that 0.1. So we're okay there. We would call it narrow. And we have a T wave that's going from above, that's going up like the R wave. So we know that it's atrial. It's coming from above the ventricles. Now we need to address all these P waves that look different. If you don't have P waves that are all looking the same, then it is not a sinus rhythm. But if you do have P waves, a narrow QRS, and a T wave that goes the same direction, you do have an atrial rhythm. And the atrial rhythm here, because all those P waves are different, it's kind of wandering around the atria, and you have different impulses coming from all over the place. And that is called a wandering atrial pacemaker. Let's see here. I'm not sure why that's black. Oh, dang it. And it's a slide that I want. Shoot. All right. Well, we'll talk about this one and then I'll tell you what the one before was. I think the answers are on the slides. And so when you go through the slides, the answers are there. Just try to walk through the slide first before you go and look at the answer and see if you get the same answer. So here, let's see, 3, 4, 5, 6, 7. So our rate is 70. We're in our 60 to 100, so we're fine with our rate. Then we look at our rhythm. If we're marching along at the top of our R waves, here, whoops, here, they look very regular. Then we're going to look at our P waves. Do we have one or do we have many? So if we have many, then they are not coming from the SA node, right? Because it only fires one for every QRS. So we know this isn't sinus, but there are P waves, so it's above the ventricles, so we would call it an atrial rhythm. With our atrial rhythm, then we look next at our QRS. And we do have, and whoops, that won't draw. We do have a narrow QRS, and it comes up, and we have a T wave. It looks very similar to all our P waves, so I'm not entirely certain that it's a T wave or a P wave, which can be kind of dangerous when those get very close to each other. So for now, we'll just call it a T wave, and then we'll say that these other three here are P waves right here, okay? So then we go and look, we looked at our QRS, now let's look at our ST segment. So I will move this over here away from all that drawing. Let me look at this isoelectric line here. So initially I thought it might be sagging a little bit, but I don't think this is significant enough that I would call it ST depression. If you were to see it on the test, you will know it. It will definitely be something that you can identify. So then we look at our T wave, and our T wave is going the same direction as our R, and it's something that we like. It's not too high, it's not peaked, it's not inverted, so we're good there. So the only thing we really have a problem with is too many P waves. So then look at your P waves. Is there a pattern to them? There is kind of a pattern, and they look kind of fluttery, and they look like a sawtooth. See how they just kind of all look kind of jagged there? When you are looking at your atrial rhythms, there's two of them in particular, look at your regularity. 95% of the time, your atrial flutter is going to be very, very regular. Okay. And about that same percentage of time, your atrial fibrillation is going to be irregular. So then when you look at, okay, I've got regularity here. I've got this sawtooth look to this. And so I'm going to call it atrial flutter. The one that was right before this was atrial fibrillation. But it's, dang it, I don't know why it's blacked out. So those were the basic two that I really wanted to show you. Let's find, oh, this one's a good one real quick too, because it kind of begs irregularity versus early beats. So your rate is 80, so we're good there. Your rhythm, so it's looking initially like it's an irregular rhythm. So what you want to do is you want to find similar P, QRS, and T waves. So let's start looking at this first one. It looks very similar to the second one, to this one here, right? And it looks very similar to this one. Not so much with this one. Okay, so that's going to be something that we're going to look at. Then this one looks back to where it's looking pretty much the same. Same with this. Same with this. So I would say that we would count our regularity from those beats that all look the same. So we'll go from here, here, to here, and then it would be about here. So then I'm looking at that beat going, that's probably an early beat as opposed to an irregularity. Then we go right back to here, whoops, and here, and here. So it goes right back to a very regular rhythm. So right here, I would call this an early beat. So now we need to look at our P waves. So don't jump to your early beats yet. They're at the tail end. P waves, we have one for every QRS, right? Nice and round and upright. But on this early beat, look at the difference in that P wave. That is coming from a different place. But then we go back to these regular ones that are all looking exactly the same. And so we know that that early beat is coming from somewhere else. Then our QRS is narrow. Our ST segment looks okay. And our T wave is going the same direction as our R. So now let's address that early beat. So we'll get rid of all of that. This early beat here kind of comes down right there like that. Does it have a P wave? Yes, it does. And it looks different than several of the others. I drew right through the middle of the difference. Sorry. It kind of falls right on that T wave there. So from here to there, you can see it a little bit better. Then you have a narrow QRS. ST segment's fine, and T wave is fine. So then you go, okay, well, it's an early beat, and it has a P wave. If it has a P wave, it's atrial, coming from above the ventricles. So then you would call it a PAC, a premature atrial contraction. So this would be a sinus, or it would be a sinus rhythm, because we have all of those P waves that are nice sinus P waves, with a premature atrial contraction. All right, we'll do one more here. Oh, actually, there's two more, because I want to do one at the very end. So what is your rate? You do count every R wave, so count this one too. So 3, 4, 5, 6. So we're in our 60 to 100, so we're okay there. Then we want to look at our underlying rhythm and see if it's regular. So we're going to look at our P, Q, R, S, T. That all looks the same. And then we're going to count our regularity from there. And then it would fall right about here. So we know we have an early beat. And then it goes right back, whoa, to being very regular. So then we know that we have an early beat right here that we're going to need to address. On your, oh my goodness, on your underlying rhythm, you have a P wave, a narrow QRS, ST segment looks fine, and a T wave that looks fine. So you know that that underlying rhythm is a normal sinus rhythm. Now we have to look at our early beat. Does it have a P wave? Nope, no P wave. Does it have a narrow or a wide QRS? It is wide. So we know with no P wave and a wide QRS that it is a ventricular beat. The other thing that tells us that it's ventricular is your T wave goes the opposite of your R wave. So that is going to be a sinus rhythm or a normal sinus rhythm, however you want to say that, but a sinus rhythm with a PVC. If you had more than one and they looked the same, then it would be a unifocal PVCs. And if you had more than one and they looked different, it would be multifocal PVCs. So let's skip to, oh, that's a good one. So what's your rate? Very difficult to count, but we know that it's super fast. So we're going to call it some sort of tachycardia. Then we're going to look for our P waves. Are there any? There aren't any that I can see. And so, oh, sorry, look at our regularity, our rhythm. I'm skipping a step. So there's 1, 2, 3, 4, 5. So it's looking very, very regular. Then we look at our P waves. There aren't any. Is our QRS narrow or wide? So that QRS is very wide. So we know it's a ventricular beat without a P wave and a narrow and a wide QRS. And our last one we want to look at is our T wave, the opposite of our R wave. That is also going to indicate a ventricular beat. So I would call this ventricular tachycardia. And then this last one here is actually the same rhythm. So you really can't tell a rate and you can't tell a rhythm. Neither one of them is very organized. It's kind of all over the place. You know, something electrical is happening because there's electrical activity that's being recorded, but there isn't anything that's organized. So then you look and say, well, if I don't have anything that's organized, no P waves, it's undiscernible if I have QRSs. This is basically just wiggling. It's just kind of vibrating or fibrillating all over through here. This is a large heart muscle that is just fibrillating. So it is ventricular fibrillation. It is lethal in 4 to 6 minutes, and you need to do good quality CPR while they are getting that defibrillator ready. This is also ventricular fibrillation down here. The amplitude is just different on both of them. One is turned up a little bit taller and one is a little bit smaller. But if you saw this and you were unsure, your number one intervention, first and foremost, is to put your eyes on that patient and make sure you go and assess them to see if they have a pulse. Because if you have this and you walk in the room, they will be apneic. No, they will not be breathing. They will not have any level of consciousness. They'll be unconscious. They will not have a pulse. They will not have a blood pressure. They will be turning blue. And it is definitely a code blue. So if you see this, double check on your patient. And that's the last slide on here. So then what I would tell you, I'll give you just a few kind of recaps on the presentations. Your ASD and PDA, that's an opening in the atrial septum. And the PDA is that little ductus arteriosus ligament that goes between the aorta and the pulmonary artery. That is a communication piece left from fetal circulation. If you have that as your only defect and it's not closing, then they will give prostaglandin inhibitors to close it. Remember, someone who's inhibited is closed up. And so if that's the only one, they will give those. However, we have big heart defects like tetralogy of Fallot, TAPVR, some of our ones that need to have that collateral circulation and need to have that little pathway to be able to communicate blood, oxygenated blood, to the body. So then they would give prostaglandins to keep that open. Okay, so with your ASD, you will hear kind of a machine-like murmur higher up, usually at like that second intercostal space, left sternal border. And it's kind of machine-like and shrill, kind of. It's a loud sound. Then your ventricular septal defect is going to be low. It's going to be in the ventricular septum. It's bigger muscle, larger blood flow. And so your murmur that you're going to hear is more mitral and tricuspid area. And you will hear more of a lower, deeper swishing sound. And likely you will be able to feel a thrill at the apex of the heart. When you have a murmur in there, you often can feel a thrill. Those two travel together. Then I think AV canal defect. So we have with the AV canal defect, they have problems with the valves and with the septum. So there's a lot of mixing of blood. However, with the mixing of blood, the left side of the heart is stronger than the right side. So you'll have a left to right shunt. When you have that shunt, you are mixing blood on the right side of the heart, which then goes out to be oxygenated. So it isn't a cyanotic heart defect initially. This is the one where you have blood coming from the left side of the heart and blood coming from the superior vena cava that's kind of overwhelming that right ventricle. And it pushes blood out to the lungs. With all of that heavy blood flow, excuse me, with all of that heavy blood flow to the lungs, it can start to scar those lungs. So if this isn't repaired and it starts to scar those lungs, and they will start to put back pressure. When that pressure starts to rise in that right ventricle, it will then become a right to left shunt, and that is where you will see cyanosis. So that's if this goes unrepaired. But initially, as an infant with a new AV canal defect, that is an acyanotic heart disorder because the mixing is happening on the right side of the heart. This is the one that about a third of Down syndrome patients have. It's very common in that population. You have your tricuspid and pulmonary atresia. Remember where those are happening. Tricuspid is your tricuspid valve. Blood flow cannot get from the right atrium to the left ventricle, to the right ventricle. Can't get that way anyway. But from the right atrium to the right ventricle, it either can't get there well or it can't get there at all. So if it's not, oh, my thing timed out here. So hopefully I'm still recording. Yes, okay. my computer screen went black. So when you have problems with that tricuspid valve, you need to have collateral circulation. That PDA has got to be open for communication. And they would need to do surgery on that valve. Likewise, with pulmonary atresia, it's happening at the pulmonary valve. So think about what's happening there. We're not able to get blood very well out to the pulmonary bed. That's going to cause a lot of pressure and a lot of stress on that right side of that right ventricle, and it can start to hypertrophy. So think about your problems and what results from them. We also have aortic and pulmonic stenosis. So aortic stenosis, you've got a stenotic or a narrowing or thickened area that's going out to the body, out the aorta. And so if it's narrowed and thickened, it's going to put back pressure. That left ventricle is going to have to work really hard to shove blood out to the body. But pulmonary stenosis and and aortic stenosis are not cyanotic heart disorders because your blood is oxygenating just like it should. It's just very difficult to get it where it needs to go. So it puts stress and pressure on the chamber that's right before it. Your cyanotic heart disorders are all of your T disorders, plus your peaches are healthy, pulmonary atresia, and HLHS. So those are your ones that are going to be cyanotic. When they are cyanotic, that baby is bluish and dusky at rest. No stress is needed for them to be that color. With your other heart defects, if they are very stressed, or they've been eating, or they've been crying, there is a possibility that they can turn kind of blue. When you have your tetralogy of Fallot, there are 4 heart defects. And when you have those 4 heart defects, they have surgeries that are step-by-step that are set to fix those. But just remember that they have the 4 heart defects and what is happening with that heart there. And that was my story about the little gal that was at primaries that was a tetralogy baby, and she was about 4 years old, and she had clubbing. She was the earliest that I had ever seen clubbing. So remember that clubbing is a later sign. It's not something you're going to see in an infant. Then you have coarctation. That's that narrowing of the aortic arch. That's putting back pressure back down the aorta into the left ventricle. It is very, very hard to get any blood through there. And so having that PDA that helps with oxygenation also can help with circulation, because sometimes the coarctation is before or pre-ductal, before that ductus arteriosus, and sometimes it's after. So depending on where it's at makes it more urgent to get that repaired. It's kind of like when you take those long, skinny clown balloons and you twist it and then you untwist it, and it's got that narrowed airway. So you've got this big vessel and then this really narrow spot. That needs to be repaired. Often it's resected and they just cut that part out, and then they anastomose the ends or sew them back together. Let's see here. This keeps shutting off. All right. Then you have, let's see, what other ones am I trying to think of? Truncus arteriosus. There's one trunk, so those vessels don't split. So think about what's happening with your circulation there, and which they don't crisscross. Basically, they don't go out to the lungs and out to the body like they should in transposition. So with transposition, you've got 2 separate circuits, and if you don't have collateral circulation, you will not be able to get oxygenated blood out to the body. So that PDA needs to be open, and they will give prostaglandins. That is also a T defect, so it is cyanotic, because blood is mixing through that PDA to be able to get out to the body. Then you have tetralogy of TAPVR. So that's the total anomalous pulmonary venous return. And that is a total anomaly. So there's with your pulmonary venous system. So those pulmonary veins should come back to the left atrium, but they're not. They're coming back to the right atrium just to go to the right ventricle and back out to the lungs. So it just makes kind of a circuit that's going the wrong way also, kind of like transposition does, where those don't go out to the right place. And so you won't be able to get oxygenated blood to the body if you don't have a PDA or a way to communicate. So just remember that those vessels come back to the right atrium instead of the left atrium. Hopefully that gives you kind of an overview, some things to remember. With your coarctation, remember with that pressure in that aortic arch, you're going to have high blood flow or a high blood pressure in your arms to be able to shove that blood out through that aorta. And then it just pitters out, and they have a very low blood pressure in their legs. So they can be dusky and cool and poor pulses, or you might have bounding pulses in your upper extremities. It also comes off that aortic arch toward the right arm. So the right arm can be higher than the left arm too. But overall, those upper extremities can be like seriously 20 millimeters of mercury higher. It's quite a bit higher. Remember your heart failure. So which side is being affected? If you have the right side of your heart being taxed and it starts to fail, where's that blood going to back up to? it'll back up to the body. And if you have the left side of your heart that's being taxed and it starts to fail, where is it going to back up to? It'll back up to the lungs. So think about what your symptomology is and what is happening there and what you will find if you have whichever sided heart failure. Hopefully that gives you a little bit of a rundown of some of the things that will be asked. So you'll have, if you look at the blueprint, you'll have some anatomy, physiology type questions like heart assessment. You will have some heart electrophysiology, like depolarization, repolarization, that kind of thing. Then you will have your ECGs. There are 10 strips. And then there are a couple of other ECG questions. Then there are pacemakers. So with your pacemakers, know your nursing cares. It's less important to know what all the different kinds of pacemakers and all the situations that pacemakers would be used as much as it is to know the nursing cares of those pacemakers and the nursing education that we would give our patients. And then what it looks like on a strip if you were to have a pacemaker spike and then a rhythm and then a pacemaker spike and then not a rhythm, a beat. If you have a spike and a beat, then you have capture. If you have a spike and no beat, and then a spike and no beat, you have failure to capture. It's not capturing the electrical activity of the heart. And then if you have no pacemaker spike and a beat, kind of a random ventricular beat, and you have no pacemaker spike, then that's failure to pace. That pacemaker is not working and needs to be replaced. Then you will have, I believe there are 18 questions on Peds cardiac. I can't quite remember, but it is a large portion of the test. So, so look at your strips, look at your pacemakers. It was very short. I think there's 2 or 3 questions on pacemakers. So it kind of goes with the size of the lecture. Vicky's material is not on this test. So that will be on the next test. So don't worry about that. So if you have questions on that, look at your course and exam outline that's at the top of the modules, and it will give you some guidance. And then look at your blueprint that's at the top of the cardiac module. So hopefully that helps. I know that was kind of long. I didn't mean for it to be quite so long. Are there any questions, Amy, that you have that maybe somebody else might have? She probably doesn't. Either that or she fell asleep because I talked too long.
I was just saying not specifically, just, everything.
Just everything. It is a lot. This unit has a lot of information, but hopefully that helps you organize it a little bit and look at those other resources. There are the practice strips in your book. So if you look in the module, it will tell you some practice strips for the 5th edition book and for the 6th edition book. And that will help give you some practice too. Organize your thoughts for your Peds cardiac in that Peds cardiac grid. That will kind of help you draw out what's different for different things and then all of the things that are the same. Look at your patient teaching and your post-op care in that student presentation. They did a very good job on patient teaching and the ways that you would take care of your patient after surgery. So I hope you guys have a great rest of your weekend, and then I will see you Monday. Thanks for hanging with me, Amy.
Thank you. Have a good
You're
one.
welcome. We'll see you later.
Bye.
You are currently the only person in this conference.